welcome everyone. Thank you again for joining us for today's Sight and Soundbites webinar. Today's topic is research and treatment advances in low vision therapy. And our speakers today are who we all call the dynamic duo of low vision care at UPMC, Dr. Will Smith and Holly Stants. So if you've been on these webinars, you know we host these every month featuring different topics related to vision loss, hearing loss, head and neck cancer, sinus allergy, balance disorders, etc. My name is Carrie Fogel. I'm the Senior Director of Development and Foundation Relations at the Ioneer Foundation, and I'll be moderating today. As a few reminders, please hold we won't be using the chat function for questions today. What we ask that if you have a question at any point during the presentation, you can feel free to submit them to the Q&A function at the bottom of your Zoom screen. And if we do not have time to answer any questions, if they're personal in nature, or if we just run out of time, we will submit all leftover questions to Dr. Smith and Holly via email, and we can get back to you personally. And as a reminder, for anyone who misses the webinar today, a recording will be available on the Ioneer Foundation website in a couple of days. So it's my great pleasure now to welcome our speakers. Dr. William Smith is an assistant professor in the Department of Ophthalmology at UPMC. Dr. Smith received his Doctor of Optometry from the Pennsylvania College of Optometry and is residency trained in the area of low vision rehabilitation from the William Feinblum Center for Low Vision Rehabilitation. And our second speaker is Holly Stants. She holds a dual certification with American Occupational Therapy and low vision, and has an Academy for Certification of Vision Rehabilitation. Ms. Stants is the low vision team leader for CRS occupational therapy for low vision. And you will see them in our new Vision Institute down at the UPMC Mercy Pavilion, where they see patients all the time. We're very grateful for their care. So I'll turn it over to Dr. Smith to get started, and he and Holly will fill you in on the latest advances in research for low vision.
Thanks, Carrie. It's really a pleasure to be able to speak with everyone today. We'll go through some slides. I'll try to verbally describe them to the best of my ability. I'll kind of do the first half, which will talk about some of the new treatments, technologies in low vision, especially what we're doing at the Vision Institute. And then we'll turn it over to Holly and let her talk about some of the new rehabilitation strategies and technologies that are available as well. So we'll get started here. We've been in our new facility seeing patients now since May. And this is a photo of the outside of the Vision Institute at the Mercy Pavilion, which is located on 1622 Locust Street, right next to Mercy Hospital, just down the road from Duquesne. So the hospital, or the Vision Institute, has two different entrances, one being to the Vision Center and one being to the rehabilitation suite. So it's well labeled. So the main entrance is kind of under the canopy. The side to the Vision, the rehabilitation side is located just to the left of the main entrance, which I am showing right now of the Vision Institute. So the low vision division is located on the 4th floor of the Vision Institute, and we see patients that are involved in clinical trials on the 5th floor with the research program. So our parking garage is connected right to the building, and actually if patients drive all the way to the top of the parking garage, which is labeled as P8, there'll be an entrance that says UPMC Rehabilitation Institute, and that actually enters right into our waiting room, which is located, which the photograph is located on the bottom left of the screen. And the building was really designed with taking patients' input and experiences in to help maybe make a better experience for patients to be able to navigate with all levels of vision. So it's designed to be high contrast areas to make things stand out, such as the front desk, the chairs, the tables. And in the photograph, which may not be quite so obvious, the pillars are illuminated, as well as there's lighting underneath the front desk to help draw patients' attention to those important areas as they navigate into the waiting room. The low vision division consists of 3 exam rooms. The hallway that's pictured here, which we had an artist from California depict some of our patients that have participated in low vision rehabilitation. And there's a QR code that actually those patients can describe their experience with vision loss and their experience within low vision. We have 3 fully equipped exam lanes, as well as a number of rehabilitation rooms throughout the low vision division. What's really exciting about the new Vision Institute is we have a low vision rehabilitation garden, which I have 3 pictures here. And this makes it really wonderful. We're able to go outside, and there's kind of these landing strips of gravel, turf, and brick or pavement, as well as stairs to go up and down, so we can look at people's mobility. We can help make recommendations so somebody can maneuver about more safely, as well as we can also look at lighting and contrast assessments outside in a natural environment. The sensory garden also has tactile plants, plants that have smell. There's lavender planted in there, and that's actually taken care of in conjunction with the children at the Western Pennsylvania School for the Blind. So it's very nice to be able to have this present. Just to, if people are interested, there's a sculpture that's made of bronze in the garden. It was done by Southwestern artist Michael Naranjo, who is visually impaired and works a lot with blinded veterans. So we're very, very fortunate to have that for patients to be able to interact with in the garden. Outside of, well, I guess inside of the garden or out inside of the program, we have a new low vision rehabilitation life skills apartment. So this is a fully functional apartment. We have multiple stoves, multiple microwaves, refrigerators, a full functioning washer and dryer. There's a living space with a television, a bedroom, and a bathroom that contains both a shower and tub. So we are able to provide rehabilitation and provide compensatory strategies, or how would we integrate low vision devices into somebody's daily activities within their home. So we can actually provide direct rehabilitation in an environment that's similar to patients' homes, to make sure that what we're doing in clinic actually works in patients' homes, and that people feel comfortable and safe and independent within their home environment. So these, both the rehabilitation garden and the life skills apartment, have been tremendous additions to the low vision program in order to provide more realistic environments to show patients how to navigate with vision loss. So as we talk about vision rehabilitation, we can talk about some of the studies that are currently going on within vision, and specifically low vision rehabilitation. The first one I'm going to talk about is a functional study, and it's done with an Iris Vision. An Iris Vision is a digital head-mounted system, which I'll show you a picture of. And really, this device, what we're trying to look at or assess with this device is the ability to recognize faces, write a check, detect medication and make sure that that's done accordingly, as well as looking at dexterity with low vision devices in place, which is done in conjunction with the Human Imbalance and Movement Lab at Pitt. Patients who can qualify for this study are patients with central vision loss that are between the ages of 18 and 80, that have never used the device before, visual acuity of 2200 or worse, with intact or without deficits in their peripheral vision. And the picture that I have up is an iris vision device. It is a virtual reality headset that uses a smartphone to be able to provide magnification, changes in contrast, color changes, as well as some speech controlled commands as well. So we are able to look and see if this device is really making a difference in people's lives for daily activities. Another device or another study that's going on at the Vision Institute is the PRIMA or Pixium study. And this is in the area of vision restoration. So, we can talk about vision rehabilitation, which is helping patients use their vision better. This is looking at trying to restore some lost vision. This is a retinal implant done in patients with dry macular degeneration. It's implanted outside of the area that is still functional. So it's kind of implanted where there's a scar or an area of the eye that doesn't work. It's powered by infrared light. And so basically it's this implant that uses a special type of glasses or goggles to create some artificial vision in the form of light perception in the part of the eye that is no longer functioning. So this is really a nice advance in moving forward to try to restore some vision in areas of the eye that are lost. Another study that's going on is the Pioneer study, also done with the company called GenSight. And this is working with gene therapy or optogenetics in patients with end-stage retinitis pigmentosa. And so basically what they're doing is injecting, doing an intraocular injection into the eye, and it allows light-sensitive protein to utilize cells that still work and allowing them to become responsive to light, and therefore bypassing the damaged cells in the retina. So basically what we're doing is using cells that creating or changing cells that aren't used for that particular purpose. So this study is working with patients that have minimal vision to help them be able to detect objects, doorways, and even letters and words. So that can definitely impact somebody's ability to function in their daily activities. Another study is called the Prodigy study. And this is also a study for retinitis pigmentosa, but with patients that have gene defects of rhodopsin RHO, PDE6A, or PDE6B. And it's anybody of ages 18 years or greater. And basically, this is another subretinal injection to try to help gain some more functional use in patients' eyes that aren't functioning the way they should. Within the low vision program, we have access to genetic counselors that can do genetic testing to help identify the genes in patients with inherited vision loss or inherited vision retinal dystrophies. The last study is known as the UniRare study. The inclusion criteria for this study is either anybody, male or female, with a rare gene identified as the cause of the retinal dystrophy. This is for anybody ages 4 and older. And this is more of a natural history study for patients with a retinal dystrophy due to 350 plus rare genes to see if we can make classifications to help better understand both the deficits and what patients experience with these genetic conditions. So we talked some about the eye. This is a cross section of the eye. So basically we can have any problems that affect the eye, both from the front to the back. So light enters the clear cornea, enters through the pupil, which is an empty space, the black part of the eye that's kind of created by the iris, which is the color part of the eye, hits the lens, goes back through the lens. The light hits the retina, which then picks up the signal, projects it to the optic nerve, back to the brain to help us interpret what we are seeing. So really we can have any kind of issues with any of these structures that can cause loss of vision or impairment of vision. So some of these common conditions can be cataracts, glaucoma, macular degeneration, diabetic retinopathy, genetic causes, as we had mentioned before, such as retinitis pigmentosa, Stargardt's, ocular albinism, oculocutaneous albinism. But we can also have issues with stroke, so that can cause visual field defect or inability to interpret what we're seeing, trauma, as well as nutritional or vitamin deficiency. So low vision or visual impairment is really a reduction in vision that cannot be corrected with conventional or regular glasses, contacts, medications, or surgeries. And that may affect somebody's ability to see details at distance and near. It may affect somebody's peripheral vision, inability to detect color, contrast, or ability to tolerate light or changes in light. A low vision evaluation is a little bit different than a routine eye exam. We really look at taking a look at what patients want to be able to do that they can no longer do because of their vision loss. So what are their goals, whether it be seeing somebody's face, watching television, being able to read. We take a look at what a patient's able to do on the chart and compare that to how they're doing in the real world, and then kind of look at devices, technology, research, or in rehabilitation to help meet somebody's visual needs and goals. So we can use specialized devices. This is a photo of me, which is very early on in my career. Unfortunately, I don't look like that anymore, but we can use special charts to help measure patient's vision. We can look at reading charts and being able to test somebody's ability to read with continuous text sentences. We can do specialized color vision testing, which is a picture located in the top left, and contrast, which is in the bottom right. So contrast meaning the ability to detect something that's similar in color or tone. So think about that as the question, if you have a family member or you yourself, would be, is if I had mashed potatoes on a white plate, would I be able to see where they are, or would it be easier if I saw them on a black plate? So then we take all that information and look at the goals and kind of determine what somebody can see. So we can define them into different distances, such as far away, whether that's something that they're going to do for a short amount of time or an extended amount of time. So for distance, we look at telescopes. So here are pictures of monocular handheld telescopes, which can be used for reading a street sign, a sign in a grocery store, traffic signal, things of that nature. These can be mounted into a pair of glasses. These are specifically known as bioptic telescopes. Recently, within the past year and a half, Pennsylvania has recently approved bioptic driving. So those spectacle telescopes that I just mentioned have are now being allowed to be used in Pennsylvania, which is very new. So an individual must have between 2200 or better vision in order to qualify for that. Their color vision has to be sufficient enough to see traffic signals. They have to be evaluated and have rehabilitation with the bioptic telescope in place. That telescope can't be stronger than 6 times. And initially, when the patient starts out, it's during daylight only. There is some rehabilitation that needs to be done with this. It's 20 hours of behind the wheel training, 45 hours of observed driving with a licensed driver, and then a final evaluation. And then patients are eligible for the permit or to, as well as to then receive a license. Some restrictions are there's no freeway driving. It's usually a standard vehicle, commercial vehicle, no motorcycles. It's daylight if the vision is 20/50 or worse. Patients that can get 20/40 or better with the telescope can apply for nighttime driving after a year of on the road driving without any kind of violations or accidents. So that's really nice to have the ability to, because Pennsylvania is one of the last states to be able to do that. These are pictures of just other telescopes that can be used for watching television, seeing people's faces, and again, the iris vision, which I mentioned before as part of our study. For reading, we can utilize a lot of specialized magnifiers, whether it be handheld magnifiers pictured below, as we would traditionally think of. We can use very high-powered microscopic glasses that are very thick to help patients be able to see. We can use technology in the form of electronic magnification devices, both in a portable option or in an option such as a closed circuit television, which is pictured here, that can make things bigger, can change the contrast. And all of our closed circuit televisions now also have the ability to have text to speech, so they can actually read to somebody now if that is a desired goal. The iris vision can also be used for reading, and for things such as the computer, we can utilize special types of telescopic glasses or microscopic glasses that jewelers may use, that surgeons may use. So it provides magnification, but at a longer working distance. So the next thing we're going to talk about is some of our new rehabilitation strategies. I'm going to let Holly talk about them so we leave enough time for your questions. So I know a lot of that seemed very quick, and I'm trying to give just a generalized overview of what's going on. But if anybody has more specific questions about either the pictures that they may not have been able to see well enough, or questions that that pertain to any of those, please feel free to ask. So I'm going to turn the screen over and the keyboard over to Holly, and she can take over and talk about what she's doing in rehabilitation.
Hi, everyone. And what we have on the picture now is a big device. It looks like a big square, almost like what people get when they have their visual field done. It is 5 circles of LED type lighting that will be programmed by myself. And I can actually have, so you think of this as a big square and there's quadrants, there's those 4 quadrants. I can select a special quadrant to have the light come on. It can be on for as little as a half a second all the way up until 10 minutes. So what we're doing with this device, it's called the Dynavision D2. We're actually helping people to actually see how a scanning pattern could become very helpful to them. We want them to be able to look in the direction of the light to try to see the light. And because we can record their progress, we're able to take the information and look at how the training is helping them become a little bit faster, be more aware of what's in their environment, peripherally as well as in central vision. So it's a very useful device. It was designed several years ago, and this is the latest rendition. And there's lots of ways that we can actually use this to implement strategies for vision training prior to them, a person participating in a functional activity. For example, I will have someone work on this device, and then I'll take them into the apartment that you saw or heard about and have them go to the cupboard and look for things in the kitchen cupboard to see if they can scan a little bit faster to find that item, to be able to engage in their daily activities. The purpose of this is actually to not only give more opportunity for them to learn about the scanning pattern, but also to engage in a functional task so that they are helping themselves be a little bit more able to complete their activities of daily living. This other device is called the BITS. This is a great device. By the way, the Dynavision is able to be used from anyone sitting in a chair to someone standing. And it also has the capacity to have green lights, so we can change things around a little bit. And we find that people have enjoyment with it when they're trying to scan. They actually take it upon themselves to want to be a little bit faster, so they become very competitive. So I think that's also a beautiful thing for our system here, is to try to help people realize their capacity and bring them more hope. So the BITS is a very good tool that we also have as well. And we're using this also as a functional scanning capacity, where we have different programs that we can put up. One of them is the bells cancellation test, where they have to find a certain amount of bells in a certain pattern of scanning. And again, it is very helpful when a person is doing this type of thing. The feedback that we can give them is, look, when you're scanning, this is a little bit of a different pattern and you're having more difficulty, but if we can teach you to scan this way, it becomes more functional for you, so that when you're in crowded environments or you're trying to find something in the grocery store or even in your home closet, you're able to scan better and to be able to achieve success. So it's very, very useful. And it also, again, brings people to a space that they might not have had the capacity before. And right now, I think that the biggest thing that I like to talk about with our system, with Dr. Smith giving us great referrals with the recommendations as we work together as a team, is I'm sure most of you know that we're living in a technological evolution right now. And I think as time goes on, it's going to be even more apparent that the technology that's available is actually going to bring people into spaces that they didn't think they could go, because their vision has changed. And I'm here to say that there's a lot of wonderful things. Every few months, iOS systems are updating, and Android systems, and people's available use of the technology is more frequent. So maybe they have a family member that has something that they're not using anymore. Maybe you can get access to an iPad. So when I see patients, I always ask, do you have access to this technology? Because we can actually show you something today that you can take home. You can use as a camera function. You can use it as a magnifier. The latest update on iOS, if you're using the accessibility feature, what's called Speak Selection and Speak Screen, you can actually take a photograph under the camera. And if you have that Speak Selection, Speak Screen on, if you tap that, whatever you took a picture of that would have any print in it would actually become available to be read to you, so you could hear it if you wanted to be able to have something read to you. The photograph that we have up does have several items on it. We have the iPads. We have something called the Amazon Echo, which is another device that you could have on your counter, and you can ask, hey, Alexa, or, what do I have in front of me? And it will tell you exactly what it's looking at. It could be anywhere from a food product to a medication bottle. And then because technology is advancing so quickly, the bottom picture is a stove that actually can be voice activated and used with applications from a person's telephone, should they provide, cell phone, should they prefer to buy something like that. So we are living in exciting times for sure. And what you see up now is just a screen with a Seeing AI. So this is an application that I often recommend to patients if they have Apple accessibility, because this is a application that was established by a gentleman with Microsoft who was blind, and it's optical character recognition. So what it does is, using the iPhone's camera or the iPad's camera, it's able to translate that information into a character. So it's actually reading. And you can actually, in this application, there are 9 different channels. You can have a channel to read a document. You can have a channel for a quick read, like a medication bottle. You can have you can also have a product code. So you're just scanning the barcode, it'll tell you about the product. It will even give you details about the product, not just what it is, but if it has this ingredient, that ingredient, what have you. You can actually identify money. So if you're in a different country and you have difficulty with your vision, you can actually put that country's selection into your iPad, and it will tell you what the money is. It'll identify colors. It also identifies people. So what's helpful about this is if you're having trouble seeing and you have this app, you can actually take a picture of the person, program that person's name into the phone, just like you do a phone contact. And when you hold that application up, or you say, hey, Siri, open Seeing AI, who is this? It will tell you that person's name as long as you have programmed that into your phone. And these are things that we find very helpful to patients that have challenges with vision, because oftentimes in our society, the biggest thing is not being able to see faces and recognize people. And we lose that if you have some vision impairment. So it's really important to be able to have access to that. So again, this is a great application. And these are some things that we're using in the clinic to help people better connect with their environment and their daily activities. And these are some other applications that are free. Again, Prismo Go is a similar OCR reader. There are orientation and mobility applications that are also very helpful. Soundscape is another great one that you can actually use, and it will give you direction step by step, turn by turn, outdoors from point A to point B. And Google Maps, of course, is also a very good application. Some of the other things that we're using with regard to technology with the computer, it would be Zoom Text. It's a great program. It's a magnifier. You can have it up to a 30 or 40x. So if you have a computer screen that's large enough to get everything that you're able to see, it's great. And it also can read to you. And when you click on it, you can select what you want read. And things are moving fast also in the technology world with respect to computers. So a lot of the computers now are actually having some of these same built-in features where you don't have to have an add-on program like Zoom Text. And I'll talk about that in just a moment. So in the picture, we have one of our persons in our department, Deborah. She's in front of the computer, and it's just showing how the screen is enlarged with the Zoom Text applied. Again, we do have the Zoom Text, Dolphin Guide, and JAWS. These are all different types of applications that people can get for their computers to help them with access to print. And going back to the iOS system, Apple is a great company that has a lot of resources, and this is just an example of Apple V. You can, excuse me, download it, and it's like a blog that gives people a lot of information about updates and technology for Apple products. But this was just another way that you can look at, if you go into general accessibility magnifier, you can turn it on your computer, or excuse me, your computer, yes, and also your phone or your iPad. In Windows, this is a little bit of an older slide, 10, now it's up to 11, pretty soon it'll probably be 12, but you have something called ease of access that you can actually go right into your computer and type under Microsoft and look for ease of access, and you will be able to do a lot of things already built right into the computer. And you can also use something in Word or PowerPoint called Immersive Reader. So if you click on that, not only will it read to you, but you can actually figure out what the best spacing for the words are and what size are the best for you. So if you're trying to read something and have it read to you, it's very helpful. And these are all things that I would share with people if they come to see Dr. Smith and myself for the rehabilitation. There's also some other things on the horizon. There's an application called Look that actually helps people start to read better. And it's the ability to put the print up on the screen, and it comes frequently to you, and you can read it at your pace. I don't have that on the screen, unfortunately, but I was thinking of it with the application here. So in the OT evaluation, we do pick up on some of the things that Dr. Smith has already told us. When he sees patients, he tells us about their acuity and their contrast sensitivity. And we do look at all the other things as well as what he does, some of the things. We look at the ocular motor function, what's your visual attention, and how are you able to write, looking at critical print size for reading, being able to understand if you're having difficulty with depth perception. It may sound a little interesting that persons do suffer from depth perception challenges, but if your vision in both eyes are not working the same, or if you've lost vision in one eye, you can certainly suffer from some challenges with depth perception. And our main goal in our department is to make sure you're safe and you can remain safe in your environment at home. So we do train a lot of different things with looking at contrast sensitivity, looking at lighting, looking at glare reduction, and being safe in your environment, like putting something on the edge of the steps so you know where the steps end and start. again, we're looking at a lot of technology and keeping you safe at home. So in our low vision evaluation, we also look at the lighting, as I mentioned. We take a couple moments and use something called the Lux IQ. It's a little device that's located on the left side of the screen. It's a machine that we can put over text, and we have the ability to slide on the left to determine the lux and slide on the right to determine the Kelvin, or which would be the temperature of the light. So the lux is the brightness. And so we can kind of determine, looking at the paper, we can say, well, based on your selection, you may need a 100-watt equivalent light bulb, which now may be up to 1,500 lumens, which will give you a great task light for certain activities. And we really find that this is a great thing to do because a couple of the low-hanging fruits in low vision would be contrast enhancement and lighting. So I think that's very important in our department. We talk about that all the time. And so this was just an example of glare reduction and contrast enhancement. We would want to look at what would help a person with glare control and also contrast enhancement. One of the things that becomes challenging for folks when they have changes in vision is the ability to go from different types of lighting. For example, if you're outside on a beautiful sunny day and you decide to go into the theater, the ability for your eyes to change to that lighting could be challenged by a vision disease. So it might take up to 30 minutes to be able to get back to the lighting that you have in the dark area. And sometimes people with different eye diseases don't even have the capacity to change that. They have a lot of trouble. So we always talk about that because that's a good place to have a fall. So we also bring into the contrast and the glare filters to help in that situation as well. And here's just a couple of pictures of some of the things that we do with the contrast enhancement. On the left, we have a lady walking down the steps. On her right hand, she's holding onto a railing that matches exactly the same color of the wall, which is very difficult to navigate. And on her left side, she has a railing that looks like it's bright red, so it actually sticks out from the wall so she can see it better. And on the edge of the steps, there's a white, like a strip of tape, and the step is red, so you're able to see that a little bit better. We also talk about daily activities such as drinking coffee and pouring coffee, and there is a little device in the coffee cup there. As you would pour the liquid, it would beep so that you know how much liquid you needed, so it didn't overflow. But the better focus here as well is the fact that the cup is white and the coffee is dark, so you can see that as a contrast enhancement. This is just a picture that I like to share, and I'll describe it to everyone. When we talk about all the things that we work on in rehabilitation, these are excellent opportunities to discuss things such as this room that we see. This is actually a room from a facility in the area. And so what happens is we have this beautiful room that has, it's a wooden floor, and we have a dark brown chair with light brown handrails on the chair. And we also have a bedspread that's of green, and we have the railings are off-white or ivory, and the call bell is ivory. And so the purpose of this picture is to describe how sometimes glare is coming through the window and it's bouncing off of not only the floor, but it's also bouncing off of the bedspread. And these are just things that we all take for granted unless you have challenges with your vision. And so what we like to do is help people understand how simple it could be to change some things. Like, for example, on the chair, we might tell them to put a white sheet or a pillow or something that stands away from the darkness of the chair. And then obviously change some things up around the bed so that a person could navigate the call bell. We also do a lot of things with the optical character recognition, like the Orcam My Eye 2. This is a spectacle on the side mounted device. It's about the same size as a jump drive, or if you remember those little jump sticks that you could use in the computer. It's magnetic and it applies to the side of the glasses, and you just tap it and you point to whatever you're looking at as far as text material goes, and it can be read to you. It's very similar to some of the things that the Seeing AI app does. It does actually do very many of the same things. It's just different because it is in the typical glass form that we like to always go back to. Many times our patients will ask us why we can't just get a better pair of glasses. It would be stronger for us, but when you have low vision that's not correctable by glasses, that's difficult to achieve. So this is one way that you could do it. You could wear this in the store. You would be able to look straight ahead at the different signs, or you'd be able to see things on the shelf. It would read whatever the product is. So I think for us, the most important thing is we're looking at working together as a team with Dr. Smith and myself. We look at what the person really wants to be able to do, and we also look at what's most important for them, but what's safe for them. And so we're always bringing the patient into the process. I do something called the patient-specific functional scale. Well, I'll ask a patient, what's the most important thing to you and how can we get to that point? And you rate it as a 1 out of 10, 0 out of 10. And then we're looking at that specifically to try to guide the intervention, because we always want the patient to know it's patient-centered, and we're looking at everything we can to help them. It's very important to have that success, and it's very important to be able to encourage that success to keep going. As we know, there's different things that are challenging to every one of us, but we bring the hope in this department, and with the new technologies and the different rehabilitation strategies that we're involved in, we believe that we're giving the person the best experience that they can possibly have in this area. I know that I've just looked at the clock. We have just about 20 minutes left, so I'm not sure if there's more slides in this.
They can take questions.
Oh, yeah, we're happy to take questions. These are just some other things. We do a lot of the eccentric viewing, and it's basically just using the functional vision that a person has and trying to encourage them to engage in that. But Carrie, if you want to go ahead and start, if there's any questions, we'll be happy to start doing that. I want to make sure that everybody gets their opportunity to ask any questions. Thank you.
Thank you, Holly, and thank you, Dr. Smith, for a really really thorough and I think hopeful presentation on all of the options for low vision in patients that are experiencing low vision. Patients I know always just want to make sure that they're staying abreast of the most current technology, and they're taking advantage of whatever they can to keep their vision as functional as possible. So thank you for all you do. And I will get to some questions here. We have several, and please, if you have been holding on to a question, please feel free to submit it now, and we will get to it before the end of the hour. I think we'll have some time for some more other than the ones that I see here. So I'll start with the first question. Will the screen, oh, sorry, that's a question relative to the presentation today. I'll save that for later. Okay, next question. Are you teaching people how to use the verbal parts of smart TVs and learning how to use audio description in the apartment living model?
So the answer to the question is, yeah, that's one of our goals. The TV in the apartment is a smart TV. Right now, they're working on a little bit of connectivity issues with the buildings being so new that we hadn't anticipated on. That's being addressed, and so that once that's done, absolutely, the part of that will consist of part of the training with the rehab team for sure.
And audio descriptive service is a great thing to ask about. I don't know that everybody knows what that is. For example, even if you went to the theater today and you wanted to see a movie and you had challenges with your vision, you could stop at the guest services and ask them for a headset, because they should, by now, everyone that you go to the theater should be able to get that, because that way it tells you what's going on in the story, even if so there's maybe there's a conversation going on and then there's an action scene. So audio descriptive service then would describe what's happening in that scene. So it's very, very helpful. It's kind of the same similar idea as closed captioning, which helps people that are hard of hearing, such as myself. So I think it's really important that, we do share that information. And I often, when I have clients in the room, I tell them, hey, you can actually go to the website for audio descriptive services, and there's many, many things that you might not know about that you can actually have on your phone or your TV, excuse me. Netflix is a big proponent of that. So there's a lot of good information. Thanks for the question.
Thank you. Are there any research advancements relative to ADOA that you'd be able to share about today?
Currently within our department, no. I know there's been a lot of work on the basic science side, actually within our department, with optic nerve regeneration. So a lot of the studies that are going on with that continue to be on the basic science side, meaning that they're working on it in animal models and then trying to translate that into human models. So right now, I don't believe there's any active studies going on with that currently. I know there's none here. That's not saying that there might not be something at another location. It's just not that I'm aware of. But a lot of those research right now is still a lot of them are in animal models.
Thank you. I think that is a really great answer. Are there specialized instructors who are able to train people to use bioptics for driving improvement here in Pennsylvania, to use bioptic devices?
Yeah, sure. So there's through the Department of Motor Vehicles, they have a website that contains information for bioptic driving. There are both optometrists, low vision specialists that have been certified through the Pennsylvania Department of Motor Vehicles, as well as rehabilitation specialists such as occupational therapists like Holly, and certified driving instructors. So it's kind of a team approach. The bioptics fit measured. They do rehabilitation outside of the car with the bioptic, go into the car, and then are observed with or worked with a certified driving instructor. So all of those, there should be a list of resources within the Pennsylvania Department of Motor Vehicles on their website.
Fabulous, thank you. Would a low vision rehab program be helpful to somebody who has low vision in one eye, but the other eye functions normally with glasses?
So my answer to that is yes. And we often get the question, even by some of the doctors that we work with or in the community, as when I should refer somebody to the low vision program. And I think it's a really good question, because I advocate that patients are sent really early in vision loss, or really if somebody is having a functional challenge within their daily life. So whether it be that they can't maneuver stairs because one eye doesn't work well and the other eye does, or they're having difficulty measuring or pouring because of that, I think that would be an absolute indication of somebody to come to low vision. So we really find that the earlier people get involved with low vision services, they're more successful, and we're able to get them connected even with community resources such as the Bureau of Blindness and Visual Services, Office of Vocational Rehabilitation, the Veterans Administration, any of those other agencies that can then go into the community and provide instruction is really, really important.
Thank you. There are a couple of questions related to kind of the length of time that a patient would expect to undergo low vision rehabilitation. Is it something that just requires a few sessions, or is it more of a long-term process?
So I'll talk just on my side, and then I'll let Holly talk about her strategies. So I would say a typical low vision exam is probably about an hour to an hour and 30 minutes long, and that's really for the evaluation to figure out how the eyes are working, what might benefit somebody. And then the rehabilitation program, I think, really is dependent on the patient, and I'll let Holly speak to that a little bit.
Yeah, it's a process, and I think the most important thing is to recognize we want to help build some skills. We want to help those skills being carried out, not only in our department here when they're working with us, but also in the home. And so they come back. So we always say it can be anywhere from 3 to 6 sessions, and it's not like you come 3 times a week for 1 week, 2 weeks. It could be 1 week or every other week, or it could be a couple of months, because we want to see the progression that the person is doing with their home program. And if they've gotten the optical device that was recommended, we want to make sure that they're still being able to use that as often as they can. And just to make sure that we're ensuring that, because we don't want to promote any type of device abandonment. So we're really careful about that. So it depends. It's one of those questions that it depends. It can be any, and if someone just needs something that's a simple, straightforward solution, then it might be that they only come for an evaluation treatment on the same day and then they're done.
Thank you. So it seems like there's there's a range of
Mhm.
of options for people depending on what they're experiencing.
And I tend to, which I think our clinic differs, maybe is a little bit different from maybe how other places do it with throughout the country, is I really like to keep a close eye on our patients. So I like to see them at least once a year. This way, if we are finding that things are not really working the way we want to, a lot of conditions that cause vision loss are progressive. So we like to get, if there's things that are changing, I like to see them more frequently, just because we can make interventions more frequently, and then therefore it just is an easier process for the patient, I find.
And I think one last thing I would like to add to that, because we're right next to the Rehabilitation Institute, if we're working with patients that have changes in their vision that might also relate to balance changes or other issues like that, we're happy to provide additional resources to them, so that maybe they need some physical therapy as well, so that they can stay as independent and safe as possible.
Great, thank you. I have a question here related to the Dynavision device that you were talking about. As the training progresses using the Dynavision, is walking towards and away from it with focus on one's vision added into the training?
Do they get closer or further away from the device?
That's a good question, and that is a possibility. The thing I will mention, that you have to be within arm's length to be able to extinguish the light. So yes, we can do that. There's lots of different things we can do with it. You can even put a Post-it on one side, and they have to look from one side to the Post-it and one side, somewhere else. So it is a very dynamic and flexible device. And yes, it can be that we can do it that way as well.
Thank you. We have a couple of questions related to additional things that a patient with low vision might be able to do to kind of improve their overall functionality, health, etc. Do you recommend certain vitamins? Do you recommend certain exercise? Etc. What would be of the greatest asset to the low vision rehabilitation program?
So I think some of if we're talking about like vitamin supplementation and things like that, we really do go over that both in the low vision evaluation and with their other eye care providers, whoever that may be. So we find out if somebody is, one of the questions that we often ask, what somebody's taking, and making sure that, number one, that it's safe for them. So sometimes vitamin supplementations for certain genetic conditions we would not recommend. So we want to make sure that we know specifically the cause of the vision loss for sure. And then, yeah, I think going through both vitamin supplementation, referring to community resources for other types of interventions, either mobility instruction within the home, partnering with neighboring agencies to help with employment, things like that. So we really do try to take into consideration both the eye health, the causative agent, what's likely to progress, how can we slow the progression down if we can, the rehabilitation, and then the community integration.
Thank you so much. Someone's asked a question about personal mirrors that would help somebody who's kind of looking, working on their appearance, if there's something that could help them see themselves better at home.
So there's a lot of different type of mirrors out there. Some of them are illuminated and some of them aren't, anywhere from at least 2x to at least 15x. So yes, there is something that would definitely be useful and helpful. And we can definitely help you with that. There are some magazines that you can look for, such as Maxi AIDS or LS and S, that do provide those types of things. And if you do a search, if you have the availability to do a search on Amazon, that's also a very good resource. But definitely, if you have a question, we might be able to give you better information through an email.
I would kind of also, just advise patients or people that are in the public, sometimes these things can be challenging to order through a catalog because you really don't know what you're getting. And the catalogs will oftentimes advertise something might be a 4X, but it's really not the equivalent of that. Different countries who manufacture things use different calculations of magnification. So a lot of times it's better to kind of try it. We do have a lot of options here for that, or as well as like if you went in the store to try to physically try it out, I think is something that I advocate for that. There are also, sometimes we can do these glasses that have the one lens is on a hinge. And so we can do a higher power in one eye so somebody can get closer to a mirror. The other eye is left free so the makeup can be applied, and then it goes vice versa. So there are those options as well.
Thank you so much. We are running a little bit up close to the time that we'll have to end the webinar today. But there are several questions that I see that are related to research and therapies that may be available for different conditions. And we will take those, the Eye and Ear Foundation will take those, and we will send them to the correct expert in the department, whether it be Dr. Smith and Holly or somebody else in the department that can talk specifically about a certain condition and what research and trials may be available for those conditions. But I just want to end today with what you would tell somebody if they were looking to assess whether or not they needed to be seen at the Low Vision Center at the new building, or anywhere else. And if I have a couple of questions about insurance, so if that is part of it, then great. But if not, I think people just want to know how they can get connected with the Low Vision Rehabilitation team.
So it's a good question. I mean, I think a lot of times having the conversation with your eye doctor is really important, because a lot of patients have heard over the years that there's not much left that they can be done because their vision is at a point where now it's stable or it's worsened enough. And I think there are a lot of things out there, whether it be optically or technology wise or rehabilitation wise, that's probably not a great answer anymore. So I think starting there would be great, saying, hey, I have this eye problem. I'm having difficulty seeing. Do you think low vision would help me? I think that's a really good, or low vision evaluation to help me. I think that's a really good starting point. I also feel that patients really could act as an advocate for themselves and feel that if you are having difficulty seeing and you really haven't been able to make that better by trying different things, whether it be, I tried a number of pair of glasses, they just don't seem to work. My family member has bought me a handheld magnifier over the counter. It doesn't seem to work. I think then, by contacting the Vision Institute or contacting, somebody that does or provides low vision services, I think really, it really can change how somebody feels about themselves, or may change their independence, or may do all of those things. As far as insurances go, the evaluations are typically covered by most insurances. Devices or sometimes are dependent on the insurances. However, we have access to different agencies that can certainly help get devices into hands of people that need them.
Thank you so much. So I would encourage anyone here on the call today, if they're interested in getting a referral to the Low Vision Center, to please work with your eye doctors, and hopefully we will see you if we need to. I will probably end the webinar here today, seeing as that we're right at 1 o'clock. I want to thank you, Holly and Dr. Smith, both so much for taking the time to go over everything with us regarding low vision and all the advancements in care. I hope you have a wonderful weekend, everyone who's joined us today, and we hope to see you at our next webinar. And again, a recording of today's webinar will be available on the Eye and Ear Foundation website in just a couple of days. So thank you again.